That button. This is going to go terribly wrong. We've never done all this at once.
Hit what button?
The red button with the music, AJ.
Oh, yeah.
I'm so anxious.
Gosh. I need to find somebody on Craigslist that can do a better job.
Go. Boom.
What happened?
We're recording.
Oh, okay.
I was waiting for 3 seconds of silence.
Well, you're not going to get it. Hit that button. What's going on, everybody? If you're like, hey, that song sounds a little different. I was going to wait till episode 200 to change it up, and I was like, no, you know what's a better episode? Episode 181. That's a way better episode to change up the theme music after all this time. So there you go. AJ, what do you think?
Extremely memorable.
Seal of approval?
I love that number.
181, it's a good number. So we're joined by some guests today. Obviously, Cole is not with us. He's doing some family stuff today. So in his stead, we still do have AJ, who is working the cams and all that stuff behind the scenes. And we're trying to do this live as well. We're going to see which kind of a disaster this turns into. And we also have two P4 students, one from USC, one from South University. Olivia, Austin, what's going on?
Hey guys.
Hello.
Austin refuses to put the microphone up. He doesn't want to. I had to talk him into being on here. He's going to do great, though. Olivia's not even sort of nervous.
Not at all.
Good. See? Fake it till you make it. But we're going to do things a little bit different today. We're going to actually do a patient case because we hadn't done one of those in a little bit. And we had kind of an interesting case at the clinic the other day, and Olivia got to help out with. And so I think it'll be pretty interesting, if nothing else. But before we do that, Olivia, how much longer do you have in pharmacy school?
Let's see. Today is Monday, so 4 days, I think.
4 days, almost done. AJ has so many left. Austin, you're a P4 as well, or P3, I guess. Is your a 3-year program still, or is it 4 now?
It's still like the accelerated.
Accelerated?
Program. Yeah.
How is that? Do you feel like it's been just drinking out of a fire hydrant?
It is drinking out of a fire hydrant, for sure.
So, and your rotations are like different lengths, right? Like, 'cause mine's the one you're with me for 6 weeks somehow, which is, I'm sorry about that ahead of time, but your other ones weren't that long, right? Did it change month to month?
The other ones were 5 weeks each.
Oh,
You're
okay.
the last one, first day here, and it's 6 weeks.
Yeah. Austin just started, by the way. I was like, hey, dude, what are you doing tonight? You should come on the podcast. You'll love it. So he's here. He's actually being a trooper, so I like it. But yeah, so a little bit different programs. But Olivia, what do you got planned for the next few months besides getting licensed and all that good stuff?
Yeah, so in June, I start my residency at UNC Chapel Hill. I'm doing their community-based residency program, and I'll be at their campus health location. So I'll be helping some college kids.
That's
in the
awesome.
clinic and the pharmacy.
You think you're going to end up doing PGY too?
I'm thinking about it. Maybe a PGY2 and AmCare. I really enjoy this.
Good deal. Awesome. Are you thinking community? What path you heading down?
Community probably suits me the best.
Yeah.
So.
Have you thought about doing a residency path at all, or does that just not sound appealing at this point? There's no wrong answer. I'm just asking.
It's super competitive, and I feel like I'm an old dog.
Oh, please.
Old game, so I don't know if I want to,
So for those of you, and for all of you, because nobody knows this except for like maybe 3 people, but when I got hired on as a pharmacy technician at 18. Basically, the pharmacy manager did a guy that knew me a favor, brought me in. I didn't know what ibuprofen was, and there was a senior tech there who was given the task of training me, and so he had to train this punk, 18-year-old kid who did not give a crap about being a pharmacy technician at the time, and that was my man Austin here.
Yep.
So now he's about to be a pharmacist, and we're hanging out again. So it's kind of crazy. When he had hit me up about being in the rotation, it was cool. So I haven't seen him in a long time, and he got me started basically.
Full circle.
So yeah, there you go. There's your history for the day. So before we jump into the patient case, AJ, you got a pearl of the day for us, my guy?
I do. And so our pearl of the day from pearls.com with a Y, Pyrls, is when used for smoking cessation, bupropion should be started 1 to 2 weeks before the quit date. Generally, the longer the medication has been started, the greater the craving reductions may be.
pearls.com/coreconsultrx. You can sign up for a free trial. There's a free version and the paid version, but if you sign up through our link, then you will get some free charts and some good stuff to check out, and there's no obligation. So make sure you give that a look, see what you think, and support those who support us, as I always say. All right, Olivia, let's tackle this super easy case. To quick background, the patient came in for just what she says asthma follow-up for mild asthma symptoms. The PA that I work closely with, or one of them, was telling Olivia it was actually his patient, and he said, oh, just go see the patient. I'll come in after a little bit. And she's like, well, I haven't really done a PA type appointment before. Like, can I just watch how you do at least one? Which is a reasonable request, but I was like, no, and pushing it. So then we kind of was like, no, relax. And then she's going to watch one, and then it turned into much, much more complicated. So, I'll let her explain some of the details. But I was like, oh, good thing we didn't let her go in there by herself. So give us some background.
Yeah, so like he said, this patient, she's a 37-year-old woman, and she came into our clinic to establish care and get some treatment for her asthma. She had recently been hospitalized for an asthma exacerbation and was needing some refills on some of her medications. And she had a past medical history of asthma, depression, anxiety, and she was very open about her substance abuse disorder and told us about her struggles with crack cocaine. And so we kind of worked through each of her issues and kind of helped her work through those things.
Yes. So with a history of extensive crack cocaine use and also methamphetamine and some other illicit substances, but it was kind of a little murky as far as her true behavioral health history, because she made a couple comments along the lines of bipolar disorder, but never actually received a diagnosis of that. It didn't come across as manic or hypomanic even, but also didn't really seem extraordinarily depressed, more anxious than anything, which obviously could be from some of the things she does. But we'll get into some of that because it really can be a complex situation because there's a lot of moving pieces. She's also a cigarette smoker, drinks alcohol, and also very open to explaining, and very honest with us, which is a good thing. And so we want to make sure we take good care of her and also keep her, safe from a cardiovascular standpoint, and make sure we don't cause any other issues by using the wrong pharmacotherapy. So we're going to tackle this as best we can. Obviously, this is someone we would want to refer to a true psychiatrist, because I'm not claiming by any means to be that, or even a pharmacotherapy psychiatry specialist, but we're going to do our best shot to at least get things started. But we'll start with the basic stuff with asthma first. You want to kind of go through her asthma treatment that she came in on, or?
Yeah, so she came in and she had previously been controlled on Symbicort, but after her doctor had switched practices, she had run out of her refill on it, and she was only controlling it with just a plain ProAir Albuterol Inhaler. And she was using that multiple times a day to gain relief. And she had an acute exacerbation. And so when we looked at the GINA guidelines for controlling her asthma, there's 2 tracks to controlling asthma in adults. And so when we assessed her asthma, we were concerned about her risk for future acute exacerbations, just because of her risk factors with having an exacerbation within the last year, her socioeconomical problems, she is a cigarette smoker, and she struggled to use her inhaler correctly, as well as having comorbidities of obesity and drug use and allergies and anxiety and depression. So we were pretty concerned about that. So we decided to take a look at the guidelines, and we chose track 1, which is using an ICS formoterol as both the controller and the rescue. And she's at step 3 because she was having symptoms most days, or waking with asthma at least once a week or more. And so we prescribed her Symbicort as using it twice daily and then as needed for her reliever.
Yeah, and I think one of the misconceptions even still. I mean, this is something that changed in the guidelines back in 2019, but there's still some concern about going this route for clinicians that aren't really used to it or aren't familiar with this route, because for a very long time, the thought of using a LABA or a long-acting beta agonist in a patient with asthma was like in an as-needed standpoint was like absolutely a no-no. The box warning that was associated initially with anything that had a LABA in it was that by using a LABA more frequently than prescribed, you could increase the risk of asthma-related death. Obviously not ideal in an asthmatic patient. And what that was really coming down to was the patients who were given a LABA by itself. They went back and kind of reevaluated with some other clinical trials and looked at when you have the combination of the LABA plus an ICS, you do not see that increased risk of asthma-related death. So like the Vestry trial or the Ostry trial, which was done in a little bit older patients, Vestry was done in 4 to 11-year-olds, they didn't see those same risks. And so basically what ends up happening is the LABA, the receptors, they would down-regulate those beta receptors so that if the patient had an exacerbation, then it was something that when they went to the emergency room, they tried to give them Duanebs or whatever they were going to treat with, and it wouldn't work because those beta receptors were so down-regulated. When you give it with an ICS, it actually upregulates those beta receptors again, and at the same time, the beta receptors will also upregulate those corticosteroid receptors, and so there's like this synergistic effect with that combo. And so it's something that you don't have to worry. It is a LABA, but don't think of it, even though you're using it as needed, it's okay because it's with an ICS. Now, you still wouldn't want to do that with just plain formoterol, but because it's with the ICS, you can do it that way. And why formoterol, Olivia?
Because it is a fast-acting.
Yes, it is a LABA in that it lasts for a long time, which is actually a good thing, but it has almost the same onset of action as albuterol. And so with that, it's one of those things that, we're getting the same effects with the albuterol, but it's lasting so much longer. And if you think about like the pathophysiology of asthma, there's this inflammatory component, obviously. So when you give a steroid on top of that, you're decreasing that inflammation, and as well as causing the bronchodilation. And so it makes sense from a pathophysiology standpoint as well. And they've done studies obviously comparing that to a regular SABA and seen that it is more effective at cutting down asthma attacks per year, and also corticosteroid exposure over time, because you're getting that anti-inflammatory effect more frequently in the beginning to kind of control the symptoms. And so, formoterol with an ICS is the go-to. Usually Symbicort's the one people use. There's also Dulera, which was, I believe, has mometasone in it. So there's a couple other formoterol options. But, the other concern without the ICS component, like she was doing it with just albuterol, would be obviously her crack cocaine use. One of the side effects of extensive albuterol use is that it's going to cause the upregulation of those beta receptor activities in the heart as well, and going to cause tachycardia. And cocaine, according to my research, also can cause a little bit of tachycardia, which can cause. And there's actually been case reports of patients having like myocardial ischemia and even MIs when that combination is used together. So it's good to get her on something that hopefully can cut down on her overall SABA exposure. But I think if the one takeaway, and we've talked about this before in the podcast, but also if you're going to use the formoterol ICS combination as the controller and as the rescue, it has to be both. You can't have the Symbicort as the rescue inhaler and then have like Advair as the controller. The guidelines are very specific. There was a lot of confusion about that in 2019. So in 2020, they came out immediately, like when they redid the guideline updates, and then basically kind of cleared the air with that. And that was not their intent, and that you should be not using two different LABA ICS combos. So throw that out there too. Anything else with her? Like if you want to talk about any of the potential other treatments if we needed to escalate therapy?
Yeah, if we had wanted to escalate therapy, maybe she was waking more frequently with her asthma, or we noticed lower lung function, then we could step up to step 4, which would be the medium dose of the maintenance ICS formoterol, and then still using the reliever, the Symbicort as the reliever. And then a step up from that could be to add on a LAMA, like tiotropium, and then assess her for, phenotypic assessment, the anti-IgE, anti-IL-5/5R, and the anti-IL-4R.
Yeah, and when it comes to that last step, I kind of think about it as like, okay, look from a phenotypic standpoint, I'm thinking about the eosinophil count. I'm thinking if they have a positive, skin prick test, or if they have like a need for oral corticosteroids. And it's obviously much more complex than that, but that hierarchy of kind of thinking about how to differentiate between which option would be better. If you have a patient that has this allergic component to it, they may have an IgE level. It's between 30 and 700 international units, and then also have a positive skin prick test showing that there's this allergic component to it. And something like Xolair would be a good adjunct therapy to add on to their standard therapy. If it's an eosinophilic phenotype, and their eosinophil count is usually above 300 or more than 150 with some other issues going on, then something like the interleukin-5 receptor antagonist, like the Nucala or one of those, would be a good option. And also, we kind of tend to forget about Dupixent because it's kind of like in a class by itself. If the eosinophil counts are elevated, you can potentially consider it there. But I think about it as a really good option if a patient is requiring oral corticosteroids to maintain their symptoms. Then Dupixent is a good option for getting them off of those oral steroids, which obviously can cause a lot of issues long term. And then if none of those things really apply, then obviously we can go with the LAMA. The tiotropium is a great option as an add-on. It's coming from a completely different angle than the other two, and getting some muscarinic antagonism. So yeah, anything else with the asthma? Obviously, smoking cessation would probably help.
Right. So we talked to her just about how to use her inhaler correctly, and then considering the smoking cessation when she's ready.
I think that's something that's very commonly overlooked as far as showing because it seems so normal as far as using an inhaler, I've seen it a million times because you're around it. But there's a lot of patients that really struggle with how to actually use their inhaler. I had a patient one time, this is a true story, where telling me this is when the Spiriva Handihaler was the thing before the Respimat version came out, and he was telling me that it's just not working. I don't know. And so I had him bring it in to show me how he was using. I was afraid he wasn't puncturing the capsule before inhaling. And so I'm watching him do it. He opens the little foil pack. He goes, and it was like a cartoon. He just threw the capsule in his mouth, swallows it, and then he just breathes out of this plastic thing. I was like, oh,
no.
You swallowed the capsule. Your eyes are going to be very dilated and you have blurred vision later. But I said, well, we've solved that riddle. And so yeah, once I showed him, he's like, oh, shoot. I was wondering why my mouth was so dry. It's getting those anticholinergic effects going. But yeah, and it's something that he didn't think anything of it. You see a capsule, you've never had to breathe in the contents of a capsule before, you might as well swallow it. And yeah, so that could have been bad. He could have had an asthma attack because no one caught it. So to make sure the patients are bringing in, whether it's the pharmacy, the clinic, whatever setting you're in, make sure they take a look at that.
I actually saw in the GINA guidelines that studies had shown up to 80% of the community had poor inhaler technique. So
yeah, it's true. It's crazy. Especially with the Respimat inhaler. I like that inhaler a lot, but having to get the canister down in there and stuff, and you got to put a little effort into it. I've seen people either explode the canister or
you got to put some muscle in it.
Or it's just not even really in there, and they go to twist it and then it just shoots out the back like a bullet. I've seen a couple of interesting techniques with the inhaler. AJ, what's your favorite inhaler?
My favorite inhaler is the Albuterol Inhaler, and my doctor as a kid actually told me I have one of the best techniques he has ever seen.
No, AJ, you're fired. What is it? I don't think so. I feel like that's a lie. The Pro Air was not even around when you were a kid.
Sleek design.
Is it? That's your favorite inhaler?
Big Red.
I'll tell you which one is the most depressing. Was the Bevespi, what was it called? The Bevespi Aerosphere or something? You gotta check me up on that. That's not what it's called, I feel like. But it was it had this really cool name, and then you open it and you go, oh no, it looks just like Albuterol. I was very excited to see what this thing, what is it called?
Fact check. Bevespi Aerosphere.
That's
Yeah,
fair. Nailed it. Unbelievable. See, Olivia, never question yourself ever. Just keep going forward. Just keep moving forward and hope you're right. The other thing is obviously once this patient's symptoms are controlled, make sure that you at least consider de-escalating therapy if possible, especially as the lifestyle changes happen. She stops smoking, stops smoking crack especially. You may be able to decrease the need for the extensive therapy over time. So step down therapy is a good option as well, to see what they can be maintained on. All right. So, I guess you want to talk through some behavioral health stuff?
Yeah.
So, when you were talking with her, because you actually spent more time with her, hearing from her than I did. So, what would you describe? Did she seem like, was she describing depressive symptoms? Was she talking like more on the anxiety side of things, insomnia?
She kind of talked about all three. You know, she talked about how her living situation had recently changed, and that was really contributing to her depression. And then, you know, she previously had been clean from the cocaine before. And so restarting that addiction, I feel like she said had contributed to her anxiety as well. And then, you know, she was mostly using that substance in the evenings. And so that was contributing to insomnia.
Yes, that will do
as
it.
you can imagine, a stimulant before bed may key you up.
Yeah, a heck of a stimulant right before bed. Did she mention any sort of like hallucinations, auditory, visual, anything?
She didn't mention any of those to us.
Well, and you said that she had kept bringing up bipolar disorder, and I heard her say that as well. But did she give a reason why she thought that? Because I know there was no clinical diagnosis of that.
Yeah, she said that she had never been clinically diagnosed with that, but she felt like her mood was constantly changing. She said that she would describe herself as irritable. And so I think that's maybe where she was picking up on bipolar.
Yeah, and not that there's not like cyclical, mood swings and things like that, but for just standard bipolar disorder, I mean, it's not like people think it is where like 1 second you're just happy-go-lucky and then 3 seconds later you're screaming at the cashier and it's because it's my bipolar speaking. That's such a oversimplification and not accurate really for in most cases what's going on unless you have some kind of comorbidity, and so I'm wondering if that's just that common misconception. It's almost like when people say they have OCD because they like to put the remote away.
Right.
Oh, it's my OCD kicking in. And I don't think so. I think you just like a clean living room. And, I think people just kind of throw those terms around. I'm wondering if that's more what it is. Because I went back and looked today for a while, and I could not find anything showing that it was actually,
Yeah, I think that she was confusing the irritability mixed with, her history of depression and anxiety and kind of coming to her own diagnosis of that.
And you also have to think too with the cocaine use, especially crack cocaine, smoking, that you're getting these neurotransmitter dumps, especially dopamine, flooding your system. And that, especially over time, can lead to a lot of, sort of psychological type symptoms. You can get a lot of not even the psychiatric effects, but also physiological effects. We start getting cardiovascular, issues going on, whether it's tachycardia or, even like a tremor, dyskinesias in some cases, weight loss. It can cause like overall anxiety, agitation. I mean, there's a lot of the characteristics that she was kind of describing were sort of indicative of like a lot of patients that are dealing with, cocaine use disorder. And then the other thing is the withdrawal symptoms. So when she's coming off of it, that dopamine high makes you feel, invincible and almost could have like a manic type presentation in some cases. Not to say that there's not, cocaine use disorder and bipolar disorder is a comorbidity, but when you come off of that, that dopamine flood, the depression, the anxiety, the fatigue, difficulty concentrating, just sleep disturbance, especially like vivid or frightening dreams. I mean, all those things are like very real possibilities. And if she's been on it for and doing this for years, I mean, there's even a risk of kind of like lowering her seizure threshold, and patients having kind of like especially if there's any kind of pre-existing seizure disorder that we're not aware of. There's patients that have had a stroke, obviously long-term cognitive impairment. We already said movement disorders. There's so many things that can go wrong with that chronic use. One thing I did think is interesting, though, is the authors for the up-to-date section on cocaine use disorder were talking about looking at sort of like the screening methods or screening instruments. And so one of the questions that they ask is, in the past 3 months, have you used cocaine, crack, or methamphetamine, crystal meth? If yes, then they say, did you use it at least once a week or more often? And if yes, they ask, has anyone expressed concern about your use? And if they answer to those, that would be, somebody would need to go for further assessment. They actually say drug testing is an extremely limited role, because just because someone has it in their system does not indicate at all that they have a disorder. And I think that's so contrary to like what we typically hear about. Someone did cocaine and like they got, that's it, call somebody. And I think it's important to also realize that just because you see something like that, it does not mean that they have it. I mean, I'm not saying tell them, hey, it's good job and high five them, but I'm just saying, like, we're sometimes quick to put a label on somebody, and it may have just been something that we need to have a conversation with, explain the risks and things like that, and go over that with them. But I think I was, and this is just my personal opinion on the matter, but I think keeping that good, open, honest conversation with the patient and that good rapport with the patient to make sure that they can tell you honestly what they're doing, so that you can make sure that their health is overall taken care of and being watched out for and managed, I think is important. Because if you come at them, most people do not respond super well to dropping the hammer on them. But I'm not going to go through the entire DSM-5 criteria, because there's quite a bit to go through as far as the actual cocaine use disorder. But it goes into, the obviously needing to take it, and is it affecting their life? Is it this persistent desire? Is there withdrawal symptoms? Is there recurrent cocaine use in situations, even though it could cause harm to yourself or others? I mean, there's like those warning factors that people are willing to go way above and beyond just wanting to try something. And I think that's the difference in the way we think about it. Treatment options, though, that's where it gets hard, because the psychiatry side of things, looking at whether it's bipolar or depression or anxiety with depression, mixed features, there's so many different potential things that present very similarly to some of the symptoms which could all be stemming from the cocaine use. We don't really know. Especially with that, she's a very bad historian, and so she came in and she was taking Topiramate, and she was taking gabapentin and taking fluoxetine, 60 milligrams, and I think was that all she was on for behavioral health type meds? Double check me. AJ, you still listening?
I'm still listening. That looks like it.
Okay. Just answering questions.
I got it right here.
Oh, okay. She also was taking some Ativan as needed.
That's right. And I think she wasn't really taking that very often, right? I mean, she
said that she actually wasn't using it that often. She said that it just made her tired.
Yeah. Which, she's not tolerating that. But the question, she also was complaining of headaches, which obviously can come from chronic cocaine use as well, or it could be an underlying tension headache disorder, or migraine or something like that. But she'd mentioned the headaches, and I think she was under the impression that she was using the Topiramate for headaches specifically. But there is some data with Topiramate for patients with cocaine use disorder, and I'm wondering whoever started her on that, which we're still trying to figure all that out to get her records. But whoever started that may have been thinking along the lines of, okay, this can help her with the cocaine use disorder, as well as maybe help with some of the headaches as they come about. And also, too, I mean, if she is going to, this is a bit of a leap, but if that seizure threshold was being lowered, or she was at risk for a seizure, that could, obviously be, depending on what type of seizure and whatnot, that could be something that could combat that as well. And she what was her BMI? Because she was actually pretty obese, if I remember correctly. Because the other thing was, we talked about her appetite and everything, and that was actually not similar to what we see with a lot of cocaine use. Because usually, because it curbs your appetite so much that, overeating usually isn't a big issue for these patients, but her BMI was 52.9. So over 300 pounds. And so definitely something that, we had also kind of mentioned, because if her, her heart and oxygen demand and whatnot is going to be going up, it puts potential stress on the ventricle over time. I mean, there's all kinds of issues with, obviously, from that regard, on top of the cocaine use and on top of the albuterol overuse. Luckily her blood pressure is actually surprisingly controlled, which is interesting as well. So her blood pressure is managing so far, but it could be just a matter of time before her kidneys and blood pressure and all that stuff start to go into having a problematic situation. And so I think overall getting the cocaine use disorder under control, or at least working on that, would be the top priority besides her asthma. We think about like things like methadone or buprenorphine for opioid use disorder. I've been thinking about this a lot lately, and actually, when this case came up, I did a little bit more research on it. But I've been thinking along the lines of like, well, why couldn't we do the same thing with like Adderall or methylphenidate? And just, it's a longer acting. You don't get the same dopamine release. You get some, but you don't get the same dopamine release that you would with something like cocaine. And so could that be something that, patients who just truly have this, addictive, whether it's personality from a genetic standpoint or whatever, multiple variables, but use that as a way of keeping them safe, keeping them off of the substance that they were abusing to begin with, and doing it in a much more controlled manner. I feel like and this wasn't always the case, but from a societal standpoint now, buprenorphine and methadone and those things are looked at from a majority of people like very favorably as far as population health goes and stuff. But I feel like if you bring that up about Adderall, at least in my anecdotal, evidence, my experience, I feel like people are like, oh no, I'm not going to trade out one stimulant for the other. But one is much more safe, and there's actually some data looking at Adderall extended release, as well as the long-acting methylphenidates in patients with cocaine use disorder to keep them off of. Because it does the same, it's a very similar mechanism. Same with methamphetamine. I mean, you got to think amphetamines and Adderall's a carbon and 3 hydrogens different than methamphetamine, technically. And so, if you can control it in a way that keeps the huge, shifts in those neurotransmitter signaling, to a more controlled level, and it keeps them kind of level. I think, that's an interesting, I'm curious to see if that really starts to move forward, become more mainstream. The other thing is with the fluoxetine. She said it was for depression or anxiety. It's kind of hard to know like exactly what that was for, but she did mention that she had these like anger outbursts. I don't know if you've ever seen like patients that are getting treated for not just depression, but they actually have those like anger outbursts, in certain situations where they just lose their temper. And fluoxetine actually is the best and has the most robust data surrounding that particular comorbid situation. I've seen patients go from like being on sertraline to switching to fluoxetine, and then it helps tremendously with their ability to manage that anger associated with their depression as well. And so the other thing that we considered, because we had talked about we're going to augment with at this point to help not only with the cocaine use but also the anxiety. And so bupropion was something you could consider maybe in patients, but the problem is the seizure threshold being lowered with the bupropion, because that normally I would think that would be a good idea because of the cigarette smoking, but that would make me a little bit nervous. Plus it can cause some issues with appetite and stuff. So if she does start to lose her appetite with the longer she's back on cocaine again, that could be an issue. And it really like kind of like what to augment with. She doesn't have any signs of like, or at least she couldn't explain like any like specific event of like hypomania or mania or even really mixed features for that matter. It sounds mostly like it was only when she was doing cocaine. And so there's the thought of like, okay, if it's just depression and anxiety with the cocaine piece kind of sitting there as maybe an adjunct, aripiprazole ends up being a pretty good option in my opinion. And there's others, and there's when I say a good option, I mean it's based on limited data, obviously, but there's definitely some out there. And aripiprazole has got a very like unique mechanism of action, because it binds with multiple receptors for neurotransmission, but it's got partial agonism at D2. And so what that means is basically when those dopamine levels are really elevated, that it basically like causes like antagonism activity. If those levels are low, so like if the person stops the cocaine, they're having that depressive like funk that they feel after the fact, it actually can raise those levels back up and give you a little bit of, it's still not nearly the same extent as it would from cocaine, but you can get that agonism activity. So that partial agonism sort of like profile that it has can really help. They call it the dimmer switch effect. And so it's like if you have like think maximal activity versus like basal activity at the bottom, that aripiprazole kind of keeps them steady, depending, and it keeps that balance of that neurotransmitter, especially the dopamine activity. And then on top of that, like from an anxiety standpoint, depression standpoint, we always think of like serotonin as kind of being like this, we just need to block the reuptake. And well, what does that mean? Like, what does more serotonin in the system mean? Like, why do we have all these random weird side effects with, SSRIs or SNRIs? It's because there's so many different serotonin receptors, like postsynaptically and presynaptically. And, some of the main ones that you'll hear about is 5-HT1A. And typically you want to cause some kind of like a partial agonism at that receptor. And so it's like some of the newer drugs that are SSRIs with additional properties, so like vilazodone, like Viagra, or Trintellix, they have SSRI activity where it blocks the reuptake, but it also causes some partial agonism activity at 5-HT1A. And then a lot of the as far as like some of the psych situations, from like a psychosis or hallucination and things like that, you in anxiety as well, you want to have antagonism at 5-HT2A, and which aripiprazole also does. And then there's another receptor that's starting to get a lot more attention now. It's 5-HT7, and that's one of the it's a procognitive, basically increases like neural plasticity and like increases cognitive function potentially, and it helps with like augment the depressive effects, or antidepressive rather, of an SSRI. So like Trintellix, one of the vortioxetine is besides having the SSRI classic activity, it also is a antagonism at 5-HT7. Aripiprazole also has that activity. So it's got all these other features that can kind of help. And it also has high affinity for D3, and it has moderate affinity for D4. And there's so many different things that it can affect as far as those receptor signaling and whatnot. But but blocking the 5-HT2A is going to help with that anxiolytic effect. So it can help from a dopamine standpoint from the cocaine use disorder, and there is data showing that it can, it's limited, but can potentially improve symptoms there. And then it also has been shown, there's data adding it to like Wellbutrin in patients who have depression with anxious distress, and adding those two together. We're not doing the Wellbutrin part of it, but an SSRI in this case with the fluoxetine. And then, you can get some potential anti-anxiolytic effects in that regard. I said anti-anxiolytic. I meant anxiolytic. There we go. Double negative. Perfect. And so we ended up going with that. And again, that's one of those things. There's not like a clear-cut answer. This patient has so many different things going on, and we're working with very limited history. So that's what we came up with. Aripiprazole on top of what she was currently taking. We kept her on the Prozac because she'd been on that for a while, so we weren't really worried about it inducing, hypomania or anything like that. That the data that has showed that usually is in patients who, one, if they do go the manic route, it's usually hypomania, and also it's usually patients who have had some of the symptoms of that previously, but just wasn't recognized. And there's some data that doesn't mean that every single person that gets on an SSRI, if they did really have an underlying bipolar disorder issue going on, that's going to induce that manic effects like we kind of textbook quote. So yeah, we kept on the Prozac, kept on the Topiramate, and added a low dose aripiprazole. Going to monitor for akathisia. We still got to worry about the weight gain, which we're going to address at the next visit, because her A1C was also pre-diabetic at this point. So she may be a candidate for good old Ozempic for weight loss. And normally I would have been if you asked me 6 months ago, I said metformin for pre-diabetes, but now Ozempic will help with a lot with weight loss, and so if we can hopefully keep her happy and get her off the cocaine, at least limit the use of it, then we can hopefully help her with the weight loss as well and start moving forward, kind of those lifestyle management changes and moving in the right direction. But we'll see. We're going to kind of take it one appointment at a time, just following up in 2 weeks, and we'll go from there. Anything else with that? I know I just went on like a 20-minute ramble, but sorry about that.
No, you're good. Yeah. So
I was just nerding out for a second, Austin. My bad.
you got really excited about those receptors.
Dude, I love receptor signaling.
Love some good
Me
receptors.
and Austin, we can't get enough of it. Austin's like, what have I gotten myself into this month? This is a nightmare.
No comment.
You can make comments. It's fine. I can take it. Sticks and stones. What else? Anything else with this patient that I missed?
I don't think so. Like you said, she's going to follow up in 2 weeks. We did some blood work on her. So when we got that back, we did see that her A1C is just creeping up, and some other concerns with that. So we're addressing it as it goes. She seemed really receptive to treatment and really open about her use. And, she said she had desires to improve and get clean again. So.
Yep. So, yeah, I hope she comes back tonight. I mean, she seemed like she was really happy with the visit, and so we'll see. I hope so. It'd be great if we could keep, getting her more and more on that right track. The other thing I will mention just real briefly is her TSH was very slightly elevated. It was like 4.8. This is probably something where at this point we're just going to kind of monitor with everything else going on. We're not going to really add the levothyroxine in there. She's younger, so she would be a candidate for someone to be on levothyroxine, even if they're, what we kind of think of as like subclinical hypothyroidism. But because of all the other cardiovascular risks she already has, I think and this is just my opinion, I think it's probably best is to hold off for now, but we're going to check it again in 6 months. If it's stable, then maybe check it a little bit longer after that, but for now we're going to plan on checking it every 6 months just to see if it keeps going up. Then we'll definitely have to talk about levothyroxine treatment. Cool. AJ, what did we miss?
Sounds good. Everything's good.
You approve?
The National Institute of Drug Abuse actually has some unpublished studies about buspirone as another anxiolytic for patients that have that stress or the stress-induced relapse when they're trying to get off the cocaine and things like that. And so buspirone is a 5-HT1A agonist, D3 antagonist, the same receptors that you're saying for all of these major drugs, in using this for this disorder. It's so cool to see all these things, the same drugs, old drugs we have, being able to come back and have new uses.
Absolutely. Well, I mean, I don't know. I'm fascinated by those receptor signals. I'm a big nerd when it comes to that stuff. I just think it's crazy that, you think about like the class of drugs, SSRI, they're all the same. They're super not. And there's a lot of nuances to each one depending on what else is going on. But we'll save that for another day, Austin. Don't worry. Austin's like, oh my gosh, we have to go do this again tomorrow? It's all right. Olivia, it's not that bad, right?
No. You can make it.
It's chill.
You can do anything for 6 weeks, right?
You got it. Yeah.
Acts like we're running marathons over here. All right, guys. Well, I hope that wasn't too boring when I went on my tangent there. But if you guys have any questions, send me an email. They'll be in the show notes. If you want to reach me on any of the social media platforms, or Cole, who's not here, but you can ask him questions anyway. I'm sure he'll be good. You can reach us on any of the social media platforms. If you want to send me a text directly, text 415-943-6116. Also, don't forget to check out the Patreon account if you want to stay away from my tangents and want more of a traditional lecture style. There's tons and tons, well over 100 now, PowerPoint slides and presentations and lectures on there. Also doing any practice like board questions, if you will, for pharmacotherapy based on the lectures that were put on there. So I think the one we uploaded this past one was based on different types of anemia. So I'm going to start uploading questions to that as well. It's like $3 a month, and then you could join and then rip all my stuff off and then just unjoin for $3. This is a deal at any price. So there you go. And yeah, if you do that, honestly, if you put in that much work for respect, you get all my stuff. I won't even question it. I think it's hilarious. But if you guys have any questions or anything like any suggestions for the show, please let me know. Happy to hear thoughts. And we'll catch you guys on the next episode. AJ, hit that sound machine to close us.
Boom. Has it always done that?